The mic is live right here, just FYI. Yep.
All right, good evening, everyone. We're going to go ahead and get started. So that we can maximize time, if it's okay with you guys, we will wait to introduce ourselves until after the presentation. Welcome to the Joint Benefits Bargaining Session for JCEA and JESPA and Jeffco Public Schools. We are pleased to welcome United Healthcare representatives this evening for a brief presentation followed by a question and answer session. I also have with me Adam Barnett, our Executive Director of Total Rewards, and Christina Despaleta from our Total Rewards Benefits department as well. They will be able to answer questions that may be better suited for the district versus United Healthcare. We have approximately 45 minutes set aside for this evening's conversation. Both Robin Zander as well as bargaining chair people have received the information around our hope that you have collected questions from members, sorted those questions and deciphered what it is that you'd like to present and ask. And of course, any duplicates you've, I'm sure, combined. And we would like to ask that those be asked by members of the negotiations team or BAC representatives so that we can maximize time and ensure that all questions are heard. Audience, we appreciate you being here. Thank you. We recognize and acknowledge how important this topic is to all of us who are employees of Jeffco Public Schools. We do ask that the audience maintain a level of respect, and we allow and appreciate your snapping. I know that that is a way in which you have demonstrated support for the association voice that is in the room. And we do ask that you please keep any comments, conversations to a minimum so that everyone can be heard. And certainly you're welcome to use the lobby outside should any conversations be necessary or phone calls, etc. So without further ado, I will turn it over to you guys to go ahead and introduce yourselves and get started with the presentation.
All right, my name is Eric Palmquist. I'm with United Healthcare. I'm a national vice president for public sector, so I work with public sector groups across the nation. I'm here in Colorado, and I was a big part of this new plan, which we're going to talk about today, and rolling out under Jeffco Public Schools.
And my name is Jennifer Boehm, and I'm the Senior Strategic Account Executive, also based here in Colorado, that will be managing the Jefferson County Public Schools account moving forward.
And we're really excited about this partnership for a particular reason. Specifically, this is a different partnership for us because we're rolling out a product that we're all very excited about. And it's a new type of a plan design called Surest. And I'm going to talk a lot about that right now, and then we're going to go into a Q&A session. So if you want to go to the next slide. So just a little bit about the United Healthcare here in Colorado. We are lucky enough to work with a lot of school districts in this state. You can see some of the names up here. And we're very proud to serve public sector employees and in particular school districts. We believe that we have a role to play, and it's a very important role in making health insurance affordable, sustainable over a long period of time, and also competitive. So it's a privilege. It's also a responsibility that we have, that we take. Some of the things that we do, I think, differentiating us is really innovation. I would say is at the top of the list. And I think you're gonna see some of that on this presentation of today. Something else that we're very proud of is really high touch service. So the ability to serve you at open enrollment and really present things in a way that school district employees can understand, and really helping to resolve issues in the event that they arise. A couple call outs on this chart. We are a leader in public sector business in the state. You can see that up here on the pie chart. There's some other schools here that we work with. Something notable is a Boulder Valley School District just rolled out a Surest plan as well. So you're one of the first 2 school districts in this state to have this unique plan. But I think we're going to see a lot more Surest adoption in the future. Yep, let's go to the next one. All right, so here are some examples of things that we do to support the community. We are excited to be a partner to Jeffco Public Schools, but we've done a lot in the community with our existing school district customers, particularly around supporting student and adolescent behavioral health is really an interest of ours. We've been able to fund a lot of different types of unique programs. For example, Sources of Strength is one that I'm very involved in. But we look at this not just as your insurance carrier, and that's what we do, but we look at this partnership as being a partner in the community.
All right, well, we recognize this is a big change to the Jefferson County School District, and we have several open enrollment resources that are available for you and your families. I've summarized just a couple of those here. There's a QR code right now that is up here on the screen, but also available on your benefit intranet, where you can actually see the Surest plan in action, search for physicians, price out those co-pays, etc. You can also book a one-on-one consultation with a Surest representative. So everybody's healthcare experience is different, and you want those questions to be answered. And we've got one-on-one consultations that are available that you can schedule with a Surest representative to walk through your questions, review your medications, review your physicians, etc. We've also got 2 open enrollment webinars that are happening on May 8th and May 19th. So you can dial into those at your leisure as well. All right. All right, so in addition to the Surest plan, we do have a United Healthcare Choice High Deductible Health Plan. Very similar, in fact, it's the same benefits that you have currently with Aetna. It is a larger network than what you have with Aetna. It is our largest choice network. So same, you will actually see an expanded version of that network available to you. No referrals are needed on either the high deductible or the Surest plan. It is a nationwide network on both plans, and it's our largest network. You don't need a primary care referral. You can go direct to see a specialist. And of course, both plans have pharmacy coverage, which we'll dig into here in a little bit. So this is a somewhat challenging slide for you to read from a distance, but this does provide you with a high-level overview of what those plans will look like. Again, on the high deductible health plan, the deductibles and out-of-pocket are exactly the same as what you have today. A $4,000 individual, $8,000 family, with a maximum out-of-pocket of $6,450 and a family out-of-pocket of $12,900. Once you meet your deductible, then your responsibility is 35% after that deductible up to that out-of-pocket maximum. Again, it is the same plan that you have today. The good news is it's an expanded network. So you have our largest nationwide network with expanded coverage right here in Jefferson County. On the Surest plan, I'm going to just do a very high-level overview of it, but then we'll dig into the details of it. You'll see on the Surest plan, there is no deductible, there is no co-insurance. And what the Surest plan does is it adds transparency to healthcare. So you will know in advance of your particular physician service, whether it's a knee surgery or an allergy visit, what your copay will be for that service. There's no surprise billing afterwards, and it is a flat copay for that specific service. So again, no deductible, no co-insurance on these plans. There is an out-of-pocket maximum, so you are protected in the event that you do have a major medical incident. $5,000 for individual or $10,000 for family. You'll see here that for a primary care visit, your PCP copay can range anywhere from $5 to $105. And we'll go through the science behind that, but basically the best in class providers, the providers that provide the most efficient level of care time and time again, are going to be your lowest cost providers at a $5 copay. But you have the ability to see any provider within that network. And then you'll also see specialists, same thing, $5 to $105. Virtual visits, of course, are available for a $0 copay. I'm going to turn it over to Eric to kind of go through the science behind that Surest plan.
Right, so Surest is not a narrow network. It's not a managed care type of a product where we're trying to be a gatekeeper. It's a broad network, as Jen described. It's our broadest network that we offer. It's a plan design, as Jen mentioned, that does not have a deductible. It does not have any co-insurance. It does have an out-of-pocket maximum, but it's a copay plan. Not only is it a copay plan, but it's what we call a copay complete plan. And what that means is when you enter a facility of a medical provider and you open the door, you have services are provided, and then when you leave and you shut the door, that is what we consider to be a medical encounter. And everything that happens in that visit is covered by that one copay. That's a major difference from other types of plans where you could go in thinking that you've got a $0 copay because it's a preventive visit, and then you get bills in the mail because they did tests, right? They might have done some lab work. You might have had an x-ray, et cetera, and then you start to get bills in the mail. That does not exist in Surest. Everything that happens in that encounter is covered under that one copay. So that also helps allow members to be good consumers, and it allows you to know what your cost really is completely before you get care. As Jen mentioned, it's a variable copay model. It steers care to the highest value provider and the highest value service. So when we determine value, cost is a part of that determination, but it's more around the quality and the practice patterns of the provider. So, for example, the Mayo Clinic, right, is a high cost provider, but they rank as the lowest copay on the insurance because of the value and the outcomes of the care that they provide. So a problem with healthcare is we don't know how much things cost, and we also don't know the value of what we're consuming. You know, it's almost like, a pretty bad ecosystem. Surest is, I would say, the first form of consumerism in healthcare that actually moves. When we modeled out Surest plans for the district, we did it in a way that we would generate savings for the health plan. Our prediction is it will impact claims in a positive way and achieve about 6% of savings on medical claims. So that's a good thing. It helps the plan be more sustainable over time. It helps to lower costs slightly. But what I'm really excited about is the savings for the member. Because there's no deductible, there's no co-insurance, and members typically choose the high value providers, we expect that Jeffco members will save about 47% on their out-of-pocket spend a year. So out-of-pocket spend is what you pay out when you get care. So you can pay out dollars in co-insurance and deductibles and co-pays. That number we expect to go down and get pretty much cut in half. So that I think is the key thing that we're excited about in rolling out Surest. It's also extremely easy to understand, and it's very transparent. You can shop on an app just like you shop for everything else now, and you can see the price of all providers for the services that you want to consume. You know, another stat that I like is 82% of members who are surveyed say that they understand or they really understand how Surest works. If you compare that to a traditional health plan, like a PPO plan, only 9% have somewhat of an understanding. That means they can draw a line between the definition and the word deductible or out-of-pocket max or co-insurance. So it brings a lot more transparency and understanding to the health plan. Let's go on to the next. So here are a couple examples. So this is a scenario where we're looking at Surest against your current Aetna plans of today. So for a condition like a maternity, under Surest, the copay is going to be from $900 to $2,000, and that includes all of the services that are listed here. That would include 14 prenatal visits, 3 ultrasounds, 4 labs, and the cost of the actual delivery. Under the Aetna plans that you have today, you can see how much a member would be expected to pay. In most cases, you're hitting your out-of-pocket maximum. In Surest, you can pay only $900 for the full maternity. So that's an example of significant savings to the member. And, you know, I'm really excited about this in particular. You know, it's going to make getting the care that people need a lot more affordable. Even if you go to what we call an inefficient provider, you still pay less. So you can go to where Surest is going to direct you to and only spend a $900, but you still have, you know, essentially every provider here in the state, and you're still saving under Surest. The savings of Surest comes from the fact that about 70% of people do pick the lower copay, so we're able to steer to value. Next. Another example is a knee replacement, right? So this is an elective procedure that people can shop for, right? It's not an emergency. It's something that people can go out and actually evaluate different providers. And it's the same type of a story here. Under Surest, the highest value providers would require a copay of $590. And that includes all of these services here in a bundle. Under the Aetna plans that exist today, in any scenario, the member hits their out-of-pocket max and spends, you know, several $1,000s. Even if you choose to go to a provider that we don't think is the most efficient, you're still saving under Surest. So again, the value of Surest is driving to the most efficient, highest value providers, the most highest value types of services, but we're able to save off of the existing plans in either scenario. So is that it? That was really the gist of what I wanted to walk through in 15 minutes. So we can open it up now to a Q&A.
So Rob and Sandra are our Benefits Advisory Committee representatives. And so I will turn it over to you, and or Michelle and Darcy are the negotiations chair people. You may also be asking questions.
Okay. You all hear me? Very good. Appreciate the presentation. Just wanted to preface this conversation knowing we don't need limited time. There are a lot of questions that people have that we just want to try to get through as many as we can. So, if we, redirect or kind of cut off so we can get to them, it's not personal, it's just we want to get through questions. So maybe keep answers to maybe 2 or 3 minutes, just so we can try and get all the questions that we can. And if some of these questions kind of repeat maybe what you kind of just said, knowing we prepared these before we knew what your presentation was. So I guess the first question, again, I'm Xander Kashub, I'm a food service worker here in Jeffco. I take healthcare through the district. We just would like you to explain what United Healthcare's role in the self-funded part of the Jeffco plan is, if you could.
Yes, that's a great question. So our role in the self-funded plan is to administer the plan that our plan sponsor has set up. So we pay claims according to your plan document. We provide a reporting. You purchase a network through us. So we have a network. We have discounts and contracted rates with the providers. That's a big piece of what we do. We assist in strategy, so we could have a recommendations based on things that we're seeing in the population that could be approved. Yeah, I think that's pretty much it at a high level.
We also provide customer service, of course, to members when they call in. We support the web app. We also do prior authorizations and appeals based on the plan documents that are established by Jeffco.
Appreciate that. Kind of a follow-up, what role does United Healthcare have in recommending and or setting premium rates?
Really, we provide the data and support the consultant and the district in setting their own. So anyone set rates, but we're providing the underlying data. I honestly don't even know what rates are for our self-funded customers. I don't ever see them.
You don't. I just want to say that, I mean, there are a lot of people in this room. There's a major interest in getting at the cost and I don't want to say I appreciate all the strategies for reducing costs on the back end, but there's a severe and real barrier to even getting there because the premium rates are so high for us in Jeffco. So there's a very strong interest in trying to understand why we are faced with this barrier to receiving the current services. Pass it off to Ron.
Can you provide a breakdown of what the premium dollars are funding? And so like what percent goes to care, what percent goes to administrative costs, what goes to the broker, and what are your loss ratios?
Rob, we could provide kind of the breakdown of the admin fees. I mean, just to kind of outline it a little bit, we have an admin fee for UHC. We have an admin fee for stop loss. We have an admin fee for shared savings. All that breaks out to about 10% of our overall costs. The majority, 90% of our cost, really what our employees are going in for. They're going to a doctor that is under contract with UHC, and that doctor is performing a service which is a shoulder surgery. And that doctor is billing our self-funding plan, which is say $20,000. So the majority, although, the admin fees, I think amount to around $100. That's about 10% of the entire cost. 90% of this cost is us going in for our care, and that kind of combined into a large number, if that makes sense. But if you'd like the breakdown, we can go over it. Yeah, send it to you.
What was your loss ratio? Or the loss rate on that?
For 2 years, because we would have it for last year. I think our current loss ratio right now of our, in 2024, 2025 is around 107.5%. And we're targeting closer to 100 if we're talking about our revenue or our premiums coming in to pay for our claims. So we're not charging employees enough this year to pay for the full cost of our claims.
Hi, I'm Darcy Hasso, I'm the bargaining chair for JESPA, which is the Employee Support Professionals. What are the factors that push costs higher? I've heard that when previously it was Jeffco versus nationwide, but then it became Jeffco versus Colorado and the rates went up. I don't quite understand that when Colorado is one of the 5 healthiest states. So how can our rates go up when we're comparing statewide?
So when we think about medical trend, it's a very real thing. We like to think of it in terms of about 30% of trend is due to unit cost increases. So that's inflationary pressure on providers. So for the same service, all else being equal, they charge more year over year. You know, we've been pretty lucky here in Colorado to have pretty low unit cost trends, around 3%, 4% year over year. And that's, you know, that's been no easy task due to the inflationary environment that we've been in over the last several years. The other kind of 70% is increases in utilization and new procedures coming onto the market that are very high cost. A good example of that is GLP-1 drugs, very, very high cost. Different types of specialty medications, different types of advanced procedures, a lot of which are life-saving and really important, but do come with a significant price tag. I also do believe that we see Americans, you know, becoming, unfortunately, less healthy over time. I think we're seeing that across the nation. So that's another piece of utilization. You know, overall, we see trends around 6, 7%, maybe 8%, sort of nationally. And I think here in Colorado, it's a similar.
So you talk about utilization. So does that mean we're not supposed to use healthcare?
Yeah, no, I mean, people are supposed to use healthcare. I think the rate of using high cost procedures is increasing, right? So therefore the cost increases.
So what's for some strategies to recommend to control some of these factors?
Yeah, I mean, I think the strategy that I like the most is bringing consumerism into healthcare. It's something that has never really existed. Surest is a great way to do that. Limiting fraud, waste, and abuse in healthcare. I think some will say that can account for 20% of cost. Surest does a great job in steering away from that, and steering away from providers who do things, you know, that might not be necessary in getting to high value. Yeah, steering towards value is a huge opportunity.
Darcy, like, we have a BAC, and the BAC, the Benefits Advisory Committee.
Familiar.
Okay, yeah, and Benefits Advisory Committee really helps us to strategize about some cost savings, like you can do with that plan. One thing that we've been doing is trying to push people towards generic drugs versus specialty drugs. That's a good way of reducing those costs.
Excellent. Moving right into my next point.
And then one
Fantastic.
more thing, one thing.
Medications being covered.
I have a couple other cost savings, if you want to hear, if not, just some examples of what we're doing within Jeffco to save costs. We have a lot of strategies that we're using to try to push people towards, you know, generics, and then having a process in place for when they are needing care. So I'm happy to go into that detail. Maybe after this meeting, we could talk about it.
Having sat on the back for a few years now, one of the main strategies we have recommended to make costs, I guess, the premiums cheaper, again, that's a huge barrier to care, is to bring more healthy people on the plans. And when we have such high costs for family, such high costs for dependent coverage, we can't do that. So I think when you say the back is trying to strategize around cost reduction and we bring strategies to the table that we don't see enacted, that's difficult to hear from you because we do strategize around this.
Moving on to medications, which was great. Some people have selected Aetna because Kaiser doesn't cover those medications. Can you please go through the process of a necessary medication not being on the formulary? What is the exemption process? How often are they approved or denied? If you could dig into that just briefly.
Yeah, so on that website, there is a link to the prescription drug list with United Healthcare effective July 1. And we are also doing a comparison from your Aetna covered medications to the United Healthcare medications. And we matched it as closely as we could. It's not a perfect one-to-one match, but it was a very, very close match. Anybody who is impacted with perhaps requiring a change in medication because it is a United Healthcare exclusion will receive a letter in the mail with information about how to, what the new covered medication would be. We're also granting everybody a one-time fill of the excluded medication so that you have time because everybody's, very, very busy. So that you have time to meet with your physician and identify what is covered by the United Healthcare plan and what is appropriate for your specific condition. Members always have the right to appeal the decisions that are being made, and those are made very clear in the SPD document.
Those appeals take time period.
So depending on the medication itself, so if it's a life-saving medication, those appeals can happen within 48 hours. It all is dependent on the type of medication. Our rule of thumb is 30 days.
Excellent, thank you for that. These are going to be just yes, nos. Can you confirm that United Health covers things such as gender affirming care?
I would have to look at the plan document. I don't have it with me if that was included in the coverage.
Can you brought up the weight loss. I don't want to name a brand name and I don't know that. Is weight loss medication covered?
So United Healthcare does cover GLP-1s for a diabetic diagnosis. However, for weight loss, it is not covered.
Thank you for the GLP-1. It was there and then it was gone. How about cancer treatments?
Absolutely. Standard of care, standard protocol is covered. All of our standard of care is available on uhcprovider.com, and you can search what provisions are covered.
Thank you.
I guess, in terms of, you talked about you try to steer toward high value providers. And I guess, how do we know that you're getting the best versus the cheapest?
Yeah.
And like specifically, like, I mean, I guess I can start with just that.
Yeah, that's a really good question. So, when you think about determining value in healthcare, it's extremely complicated. But I think the easiest way to explain it is okay, so let's take an example. Let's take an example like a spinal fusion. You could have 5 different providers that provide spinal fusions. One of them might have a high cost, a medium cost, and a low cost. What Surest does is it doesn't just base it on the cost of the procedure. It looks at the underlying practice patterns and the efficacy of that provider. So one provider might really steer members towards physical therapy, really good outcomes, and they're doing a spinal fusion 50% of the time. They're also prescribing pain management the right way, and they have really good outcomes. That provider, when they actually do the spinal fusion, might be medium cost, let's just say. Another provider is low cost, but they do a spinal fusion 100% of the time. They never do physical therapy, and they overprescribe pain management. Although the cost of the fusion is low, that would be a high copay under Surest, and the other provider would be, in this example, a low copay. So the cost of the procedure factors in, but it's not the whole story. That's why Surest is so revolutionary, because until this time, you couldn't really identify value in the right way.
So do you then do follow-ups with the patients and such in terms of, did their symptoms get reduced or fixed? Or did they die or whatever, depending on. Like, is that how a big part of your evaluation?
So absolutely, we are continually collecting data, not just from United Healthcare, but from all the healthcare payers in the state and nationwide. That does look at what are the reading rates, what is the, mortality rate, all of those things we're continuing to collect, and we evaluate these providers on an annual basis to see if practice strategies have changed. Does that make sense? And I will say, when we evaluate them, if you've selected a provider and he's a $10 copay beginning July 1st, that provider will remain a $10 copay until the next plan year. So we're not going to be switching things up in the middle of the plan year.
And as one other follow-up to this, what happens if the $10 plan person, all of a sudden, because they are cheaper, gets like lots and lots and lots of demand? And all of a sudden it takes months to get in for that person. And I think I heard in earlier conversations that hasn't happened yet, but you said, it's rolling out in here, it's rolling out in Boulder. So with bigger pool of people involved, what happens when that provider all of a sudden becomes really difficult to book?
Yeah, so that could be a short-term concern that we're gonna start to steer massively to high value. And then we'd have to work through access issues. That would be a long-term win, I would say. We're having lots of conversations with providers right now, like healthcare systems, who want to know why they're scoring high on Surest. And we're able to show them, well, you're not doing these things well. If you do these things better, you'll score at the lower copay. So we're hoping that this, and I expect down the road, it will have a macro effect on the healthcare ecosystem and help just bring the to a better value place. But there could be a shorter term access barrier that we bump into. I don't think it'll be significant, but it could happen. Thank you.
And as Eric mentioned, we work directly with the healthcare partners. So if we're hearing word from HR that you're getting complaints and frustrations that members aren't getting access to care, that's when my team gets involved and reaches out to see, what's happening and how can we resolve that. So we've got some mechanisms in place behind the scenes to support that.
Thank you.
So I had a follow-up to, I guess, Rob's questions to what or who is analyzing that data to then say go to this provider, this one, like what systems are in place to analyze that data? Is it people? Is it AI? What are we talking about?
Yeah, it's a very ginormous data set because we're doing this across the entire nation. There are a lot of healthcare actuaries that have built this model and that are updating it. I believe there's AI included in it as well, but yeah, it's a machine learning algorithm that gets updated monthly and changes monthly. As Jen mentioned, the copays don't change monthly, they change annually. But yeah, I mean, it's kind of what makes Surest. It's an asset of ours.
All right, so it's been well documented that claims denial is part of the UHC business model. What guarantees can you make to all my coworkers here that claims will not be unreasonably done?
Yeah, so there's a lot of what I would call misinformation in social media. News, things that just simply are not true.
High value, high value.
Maybe I used the wrong word. I haven't been paying attention to a ton of it. Seen some things that have said our denial rates are 30% of claims. Nothing could really be further from the truth. And the way I would explain it, if you took 100% of claims, 93 or 90% we pay automatically. It's called auto adjudication. No one even looks at it. It runs through our system and it's paid. The other 10%, The first 5% of that, so half of the claims that have some need for manual review are because we didn't get the proper documentation from the provider. So we get that documentation and that 5% is paid. So now we're left with 5%. Out of that 5%, what we see, typically the issues is subrogation will be included. That's when another policy, like an auto policy, would pay primary because it was an auto accident. A coordination of benefits with Medicaid and Medicare. So another provider or another payer is going to pay a primary. So we have to review that. And we pay a secondary. There are also members who are not eligible. They don't have the UHC card. They might have turned, they might have come off the plan. It boils down to, when you think about clinical denials, which is, I think, what the 30% number that's floating around out there is getting at. We're less than 0.5% of claims we're denying for clinical reasons. And we're doing that because we don't feel they meet medical necessity requirements. And it could put the patient at risk, right? There is an appeals process. And there are things on a subject plan that it can, certainly appeal, but we're talking about less than 0.5% of claims at the end of the day.
And again, this is where I would hope that Jefferson County would then reach out to myself and my team so that we can work through those concerns with the members. All of our covered procedures are available on uhcprovider.com, and it will give you a specific list that your clinician will utilize to identify what is missing or what is necessary for that covered procedure. So again, that's really where your the strong account management team comes into play to assist with those clinical reviews.
So to be very clear, can you state what the denial rate is?
For a clinical denials, it's less than 0.5%.
Less than 0.5%. But the other denial approximately 10% based on what you said of not proper documentation of 5%, 5% of benefits that might be coordinating insurance where the insurance has expired. Am I hearing that correctly?
Well, the way I'm breaking down the 10% is claims that need a manual review. So like a live person is touching them. The first 5 in my example are paid. It's just that we needed to get better documentation. So we're left with the other 5, the last 5%. Those claims are still paid. We're just either coordinating in many cases with another provider, like Medicaid, Medicare, perhaps an auto policy if it's subrogated. So those claims are still paid. They just might not be paid by us. Something I forgot to mention, there's also a duplicate of claims in that bucket. So providers submit things to us twice very often. So we're paying one of the claims, but not both. So when it boils down to claims that aren't paid, and again, there's not all things that are always best for the patient. It's rare, but we do have a responsibility to play oversight role as the insurance carrier.
I would say request for other insurance coverage. So if we're denying it for clinical reasons, we would request medical records. If it's denied for not a covered dependent, that's another thing for denial. But again, our responsibility is to upload the plan document that's been established by Jefferson County Schools. Also keep in mind, as a member, if you are going to a United Healthcare in-network provider, that provider holds the responsibility of authorizing of requesting a prior authorization, making sure that the services are covered. And again, to protect the members from getting services that are not necessarily covered under the plan. Always recommend prior authorization in advance of any major service.
Thank you for readdressing that. I know it's not comfortable.
Can I ask, what's your process for determining the cost of claims? Like, how do you go about determining how much, various treatments are?
Yeah, so we have provider negotiations where we do that. The good news, I think, for us right now is we're in a really good spot. We're going to be negotiating with a provider group here in Colorado in the next year. And then we've already in a pretty good spot for a few years, but we sit down with providers, they give us a proposal. We give them a counter proposal and we meet in the middle. I think you know, perhaps seen this like play out in the news. But yeah, we go through negotiations.
And do you want to pay, like I know in the insurance I've had, sometimes the hospital will bill some amount and then they cover it this much, and then sometimes that other difference magically disappears. Yeah, is that?
Yeah, that's what we call a discount. That's kind of the value of our negotiations.
Okay. And so what criteria will you be using then, like next year, to assess what premium increases would be involved?
Yeah, so we set goals for different providers. We do our best to manage unit cost trend as low as we possibly can. It's a very complicated process. There's lots of different dynamics. You know, we look at things sometimes on a percentage of a Medicare. We look at this provider to do more from a value-based care standpoint. Can we advance our partnership with them? If they want an increase in costs, can we make them essentially earn it by performing better? That's a big piece of what we think about.
It's for a time check. We have approximately 5 minutes left because we started just a little bit early.
Thank you. We just have maybe one more question. I think a big, I guess, concern, you love it or you hate it, there's a for-profit motive for health insurance in America, right? So how does United Healthcare reconcile that with an ethical responsibility to provide comprehensive and accessible healthcare today?
Yeah, I think that's a good question. You know, I think that one, we have a shared interest to do what's best for our customers, to do what's best. You know, I'm particularly focused in public sector, and really, I would say, be more focused with schools. We have a shared responsibility to do what's right for our customers and for our members. We are a profit, like a for-profit company. I think our UHN, our United Health Group profit margin nationally is 3.65% for our 2024. So I don't think that's a profit margin to be ashamed of. When we look at this plan, and what we've been able to do on this self-funded plan, honestly, we're not profitable, at least for the first 3 years. We're making, you know, like truthfully, an investment. And when we do become profitable after 3-4 years, the profit margins will be pretty small. I mean, we have an admin fee that we charge to administer the plan. That's our profit. And that admin fee is pretty small. You know, you're not a fully insured group. Profit margins there tend to be significantly higher. I don't know.
I will also say that we're very dedicated to our communities, and on one of the, I think it was the second slide or the third slide, we invest in communities that we work, and we are heavily focused on social determinants of health, because we recognize that if food insecurities are there, or housing insecurities are there, or financial insecurities are present, health takes a back seat to all of that. So we work very closely with members to manage and assist them with finding tools and resources in the community that we have supported throughout Colorado and, quite frankly, nationwide.
my understanding that United Healthcare brought in $400 billion in revenue in 2024. So 10% of that is a lot of money. Yeah, just wanted to be clear. So I believe it's a little bit misleading to say that it's not a lot of profit when the revenue is so high. And I just wanted to recognize we're not here to point fingers at anybody. We're here to speak to the truth. And we want to have good healthcare. Our goal is to be taken care of. We're important. We need to be valued. And I think there's a very clear recognition from everybody here that, again, the upfront cost for us to access healthcare in Jeffco is not sustainable. So we want to understand what you are doing to support us when you say you want to support the community, because it's really important that we have access to what you're saying is a good healthcare. That's what I just wanted to be clear.
Yeah, and when it comes to nationwide revenue for United Health Group, we're a very large company. I think right now we're Fortune 5. That includes Optum, which is a company that owns providers, so owns doctors. United Healthcare is a pretty small piece of UHG, United Health Group. And then here in the Colorado Health Plan, which is one of 20 plans, we are a very small cog in a big machine. So I can really only speak to what we're doing here in Colorado, but that number, which seems monstrous, is, I would say, it's not really representative at all for activity in the state, if that makes any sense. Thank you so much.
And thank you for rescheduling to be able to speak to when members are here.
Yeah, absolutely.
Thank you, you guys. We appreciate your presence this evening. You are more than welcome to exit. We will continue with our negotiation process this evening.
Okay, thank you, everyone.
Yeah, you want to do at least a 5-minute break to, perfect. Okay, so we will do a 5-minute break and come back. Peter, you look like you wanted to say something. Go
I
ahead.
was just going to acknowledge, can we take a minute and just reset?
Absolutely. We'll be back at approximately 5.
Hang on, wait. Everybody hang on. The white guy. He can be up at like 4.
It's gonna be good.
It's during the caucus. I don't think we're gonna talk with everybody here. Are we?
Try to.
Oh.
the amazing ally. So just wanted to recognize her being in the room tonight.
Thank you. Thank you for coming. Yay. You actually showed up, so yay, thank you. You guys really show up, I'm gonna show up. I appreciate it. Did you guys get any flags on this side? Alright, they're all here. During this damn sure, you maybe get your makeup. They'll just go down to that one, make sure. I swear to God, this is great.
My doctor. Actually, she just said she's not United States. Really? Sitting.
They know exactly what to do. All right, welcome back, everyone. We are going to go ahead and get started with the joint benefits bargaining session. We have a shared agenda this evening, and we anticipate that our joint benefits bargaining session will be approximately 5:35 now to 6:30-ish, recognizing that we have the flexibility to end it early or go over. And then we will move into JCEA negotiations. At that time, certainly we'll take a break, a caucus break for dinner and break. And of course, at that time, anyone from the JESPA team is more than welcome to stay or go home and enjoy your evening. It's totally up to you as well in the audience. You may stay or you do not have to, totally up to you. So this evening, our conversation with regard to benefits exists of, as I understand it, I'm just looking at Michelle to make sure we're on the same page. You'd like us to re-present our district alpha version with the revision of the benefits offer that we have offered to both teams separately.
Yeah, I think whatever was the last offer that you gave to both teams separately.
You're right,
Which I thought was the same. I
I
don't,
don't think it was alpha now. I was looking at a different screen. You're right, not alpha. Can't even tell you what it was called because I have it called district benefits counter offer.
it should be Delta.
Delta. Thank you. And then you will present back, I think, did you say your financial presentation is first or is that part of?
No, we're gonna do our benefits presentation with JESPA and then talk about next steps and what those will look like. And then we'll reset for our negotiations.
Sounds good. All right, we will go ahead with our revised proposal based on what we have communicated to both teams. Somehow, I closed my computer. Okay, on February 27th, the negotiations teams met and we presented this counter proposal. This does include other information which has already been presented. Would you like me to go back through these things? Okay.
Yes, please.
Okay, so in your original proposal, you had indicated that employees would receive a 20% discount for school childcare. Our counter proposal is the following. The district will request that before and after school care providers offer a minimum 20% discount for Jeffco employees. For all, or excuse me, for the 25 that we manage will maintain a 20% discount for Jeffco employees. As you are also aware, we are the only ones who can control, and yet we can certainly encourage and request that our outside providers working in many of our schools do the same. Enrollment is based on space and staffing and is not guaranteed. The second piece was priority for their child's enrollment and access to district transportation to the school of choice. With regard to this request, our counter proposal is aligned to our board policy, which is aligned to state statute. Board policy JFBA will be followed for prioritization of enrollment, including a priority for students who are the child of a full-time staff member at the school for which enrollment is sought. Board policy JFBA will be followed for transportation access, spaces available in district buses, and a student desires to utilize existing school bus routes and stops without modifications. Guardians should request transportation of that should say from the director of the appropriate transportation facility. The third proposal was that all meals would be available for 50% off for staff. We are talking about food nutrition services served meals. That is unfortunately something we are not able to commit to at this time. The next, this was our original proposal, and this was the differentiated amounts of district employer contribution. This we left in so that you would have the original proposal. However, we have the revised proposal on the following slide. This original proposal included a reduction from $640 to $620 in order to make room for a subsidy for $720 to be allocated to families who select, employees who select an employee plus dependents or employee plus family plan. We have revised that proposal to the following, which has been offered to both associations in parity. An employer contribution will be made by the district. Employee benefits costs. $650 per month will be allocated to employees who elect any Kaiser or UHC medical plan offered through Jeffco Public Schools, maintaining one plan at no cost to the employee. Employees who select the Kaiser High Deductible Health Plan 2 or HDHP2 plan will have the amount remaining contributed to an HSA. For reference, that plan is approximately $185 and change. So that would be approximately a $65 monthly contribution to a health savings account. The other proposals that were part of this were regarding the EAP and the BAC. The EAP, we have modified this language. Nothing has changed from our most recent proposal. The district will maintain access to an employee assistance program or EAP. Counseling services will be made available for all employees to support their mental health and well-being. Additional services available through EAP may include mediation, prevention workshops, mental health education, crisis response, and other outreach services. Staffing will be determined annually based on employee usage data and demand. And then finally, with regard to the BAC presentation to the board, one BAC representative from JCEA, one BAC representative from JESPA, and one BAC representative from JCAA will have the opportunity to present to the Board of Education during public comment to share the BAC recommendations to the school board. The associations may also elect to use the time they are allotted on the November, December, or January study session agendas respectively to share information related to BAC recommendations. And those are the original proposals as well as the one revision. I do want you to know, as part of this revision, we are not opposed to continuing a conversation around subsidies. However, this was what we presented to each association outside of this table, and so we did not want to provide anything separate than what we'd already presented.
At this time, Callie, yeah, so we do have a slideshow with a counter. It'll be in JESPA, go. We'll have Callie set up. I believe that, you know, we'll tag team walking through any changes if there's any questions. Let's just those as we go through the changes.
Quick, I wanted to ask a couple questions about EAP.
Oh, sure, go ahead.
Okay. Okay, so the last, I guess, this proposal for EAP, it's stating that counseling service will be made accessible for all employees to support their mental health and well-being. What does accessible mean? Can you just speak a little bit more to that?
Yeah, so we are making sure that with the employee assistance program, counselors that are currently employed are working hours that are responsive to the need of our employees. So we have accessible hours during the day, after work. I'm not sure they're offering weekend hours. They are also offering counseling services accessible remotely or in person. And on the we are also increasing the amount of time that is offered after work hours because we know that that's the highest demand area. Additionally, our counselors are very flexible in the ways in which they make available emergency appointments to our employees. So they do also have the ability to add hours. Many of them are not full-time by choice. And so that they can have more counselors. We've actually offered to, if any of them want to increase to 40 hours a week, and most of them appreciate the balance of their own work and life, and something that they individually are able to do. And so we're adding more counseling time after hours in the form of FTE, just so you're aware. And we are also allowing add hours so that if they were to have to respond to an emergency or set up additional counseling time, that is available to them as well.
I've had a few conversations with the folks over the EAP, and I would push back saying that they absolutely would like more time. I've heard directly from them that they do not have enough hours in the day to be able to meet the needs of workers. Another question around EAP, is there any intention to cut other employee programs to pay for the increased hours, people, or accessibility?
Are we cutting other programs to increase the EAP?
Correct.
We are not cutting other programs to increase the EAP. However, I can tell you that we are increasing hours at the EAP for one employee in particular to take on some of the wellness responsibilities so that we can bring those two things together. Certainly, as you know, wellness as it currently exists, some of that might continue in the same way it's always been. Walktober, spring into motion, those kind of things. And it may look different now because it's together with, eventually it will be together with the EAP. We felt as though that made sense and not to live in the student services since it's an employee support program.
Okay, appreciate that. I just know that I just want to be clear. We believe that the EAP is a benefit to employees, which is clearly why we're talking about it at this table now. Over the years, I mean, I've been here for 8 years. I want to say over the last few years, there's been significant cuts to EAP, which is an employee benefit. So I just want to make sure that as we go kind of try to right that ship to make sure that we have increased supports for workers through the EAP, that we are not cutting from another program that is supposed to support workers. Just want to be clear.
Yeah, I mean, is there another program you're thinking about that we would potentially cut? Okay.
I know I'm not. I just want to, if this is the proposal from Jeffco to increase accessibility hours, after whatever you want to call it, I just want to make sure that it's not the district's intent to then take the money needed to do that from another employee benefit.
That actually comes from my budget.
Very good.
And I am, I'm not reducing any other staff members. I am reducing, potentially access to, consultancy, which may be beneficial. And so, for example, one of the, consultants that we've used is a consultant called, Cura. And Cura has done some of our market analysis for salaries. And we did not use Cura this year. I believe we used them last year. And so some of that funding is now going to be shifted over to support additional counseling time from the Chief Human Resources budget and the total rewards budget. Both will be shifted. However, let me give you an example. One of the things that we invest in is a program called Aspire. And Aspire provides a pathway to adding a special education endorsement onto a teacher's license, or I believe they also have para to teacher pathways with regard to those who hold a bachelor's degree and might want to become a teacher. We are dedicating $135,000 to that. That is not being cut. Matter of fact, that is being continued because there is so much interest in it. So that's just one example of an employee benefit that we're offering that I'm not cutting. And so, no, I'm not intending to cut any plans. I will tell you, I just want to be very transparent. There was a staff member who was working in employee wellness. That staff member resigned and is no longer in Jeffco. They were for the state or somewhere else. We're not replacing that staff member. It wasn't actually my staff member, but we are moving one portion of their work into the AAP, not without additional staffing though, with additional hours. And so I just wanted you to know, to know that transparently in case you heard that that person no longer exists and now they're moving this program. And so, but that wasn't their full-time job. Most of their work was around student services and student wellness. They just had a small portion that was employee wellness.
Appreciate that.
Sure.
Okay. Yeah. Okay, so we have JESPA JCA counter proposal. I believe you said this is Echo version. Very good. So as we've been proposing and trying to negotiate for years, our interest is in a percentage-based contribution model. So we want to clearly state that we are demanding a benefits proposal which includes percentages. And it's a breakdown as follows. So for the benefit structure, a non-taxable employer contribution will be made by the district to cover the highest cost to cover benefits cost. The highest cost employee-only plan for each provider will be covered at 90%. The remaining employee-only plans are covered by the district at 100%. The highest cost employee plus spouse, child, and/or family plan for each provider will be covered at 75%. The remaining employee plus spouse, child, and/or family plans are covered by the district at 80%. Yes. And I just wanted to state also, as we as I alluded to before with the presentation with UHC, that the Benefits Advisory Committee for years has been trying to recommend a benefit structure that is percentage-based. This is something that has been, for lack of a better description, obstructed. In one way or another, we have had support from the Jeffco School Board to shift to this model. And it seems to be the only obstacle in the way is this table. I don't quite understand what the obstacle is when it comes to shifting. And honestly, I'm not talking about the cost. I'm shifting the model of benefits to percentage-based. What that would do is it would have the district have a actual buy-in and consequence to rising healthcare costs. As it is now, the overwhelming burden falls on employees every single year. Every year I've been here, it's unsustainable, like I said before. And I just want to be very clear that we can't continue to hold that weight as employees. We're pushing people out of these plans. We are not able to support families or students or children on these plans, which would in turn help them be less expensive. So we are urging this district to listen to this recommendation and take it seriously.
Amanda, like you had said, you talked about the subsidies being those benefits are negotiable. Just want to make that clear that this is our counter. We'd like to hear a different percentage dollar amount.
Thank you, Darcy. Okay, next slide. We heard your rationale at the last, when we got your last proposal. And so we have agreed to that language. We understand the reason behind it. In the next section, we haven't highlighted or accepted it yet. We're taking another pass at this piece where employees would receive priority for their child's enrollment and access to transportation for a school in the articulation area in which an employee currently works. And the reason we're adding that in is because we've heard from a number of our members that, you know, they might have that priority within the school they teach, but they're an elementary school teacher. And when that kid goes to, you know, middle school or vice versa, that it's been problematic. And so we want to make it easier on our employees to care for their children and to pick them up and drop them off in a timely manner. And we are thinking that this could be a compromise. So we've left that in or added that in and left the language, you know, in the balls in your court. And then the last piece, we did accept that. We also understood the rationale behind why that was struck. Okay, so on this slide with EAP, so we have added back in that the district will maintain a fully staffed access to employee assistance program. The district will employ four full-time counselors and one full-time office assistant to provide counseling services for employees and their family members to support their mental health and well-being. Additional services through EAP shall include individual counseling, group mediation, preventative workshops, mental health education, crisis response, and other outreach services. And an important piece of why we've added in that group mediation is because when we shifted maybe positions out of EAP and into these HR partners, when we have conflict within a department at a school, they are maybe not, it's not going to be as functional, it's not going to be as helpful to have somebody that they view as a boss, somebody that they might not want to have those discussions in front of. EAP is an objective third party that is, you know, that's maybe not your I don't know if evaluator is the right word, but somebody who's has maybe that power over you. There's a power perception differential there. And so we feel it's really important that say if a department and within a school needs that help, that they have a EAP available for them. Because what I'm hearing is that they would not feel comfortable having their HR partner come in to do that work. So we feel that's an important benefit to the, you know, positive relationships within our schools. And finally, with the BAC representatives, again, we haven't necessarily accepted this language yet, but you know, it's not struck, so we're willing to work with that. The part that we changed was to present the Board of Education and to share the BAC recommendations. We took away the during public comment. We feel that that is not the best venue to present that because it's a one-way communication where we're just saying things and the school board cannot have that dialogue with us. They can't ask questions. They can't really get the full understanding of maybe why the BAC is recommending this over that. And so we feel that dialogue piece is really important and that they may use that time during study session agendas to go over those recommendations.
I just have two quick questions. In the EAP one, just for clarity's sake, do you want it to say shall or may include? I don't think it changes the meaning, but sometimes we go back and forth between shall, may, will. It says through EAP shall, may include. I just want to make sure we counter with the correct.
Which line is it under the AP?
It says starts with additional services.
I'm gonna shut this down.